Welcome to the Frank and Lizzie Show. Today with us, we have the Alliance of Wound Care Stakeholders. They're going to offer an update on a lot of things that have been changing. They change quite frequently. But for those of you that are not aware of the Alliance, let me tell you that they're the leading advocacy group for wound care, and they've been busy, but they leverage the collective power of the wound care community to promote quality of care, but also to promote access to products and services that we need in our field. And so I'm Frank, I'm one of your co-hosts, and I have Lizzie, the beautiful Lizzie, with me too.
Thank you, Frank. Good morning. So I'm excited to have the Alliance back. As you know, we've been getting these regular updates from them, and I'm so grateful for their time. So in our last interview in August, we spoke to them about some of the proposed rules that were issued over the summer regarding the agency's proposed payment for 2025, specifically some of our physicians' fee schedules, home health, and hospital outpatient prospective payment rates. At that time, we had kind of encouraged our viewers to go back and to stay informed about the provisions, and the rules were just proposed at that time and up for stakeholder comment. So, while thousands of comments from organizations, companies, individuals, practices have been submitted, we know that the Alliance and its members comments are focused on wound care. So today we want to hear about those updates and recommendations moving forward for CMS. So first, let us introduce Karen Ravitz. Welcome back to the Frank and Lizzie Show.
Thank you so
Welcome.
much for having me. I appreciate it.
Yeah. So let me just start off. I want to just offer an update for some of them because I think the two of them that we talked about last time were the provisions for blood derived products and caregiver training services, which obviously is going to impact our wound care community largely. So, can you speak to what some of the issues were that the Alliance flagged on those recommendations and how it helped elevate it to CMS?
Sure. So thank you again for having me. And the
Yeah.
autologous blood-derived products for chronic non-healing wounds is a covered service under a national coverage decision. And that decision was issued in 2021. It was redone in or revised in 2023. And the reason for that, and in that revision, it included a code, GO465, and that code included both the product itself that was used for the treatment, as well as the professional time and effort that goes into preparing the product, evaluating the patient, et cetera. All those steps, that are involved in delivering the care. The issue that the Alliance had with the proposal is that throughout the time when this was issued as a national coverage determination, it was contractor priced. And the pricing was so low that there wasn't access to this product at all because you weren't getting reimbursed adequately for the professional time or the product itself. So, in this proposal that CMS had, they decided to create a national price or national reimbursement rate for autologous blood derived products. So, we were happy that they did that because obviously we want this to be more, not as disparate, not as changed, not as variable across the country.
Hmm.
But as I mentioned in your last show, the reimbursement how they created the reimbursement rate, they crosswalked it to CTPs or skin substitutes. And in doing so, when you do the math, the reimbursement would still be too low. It would not cover the professional time and effort of the clinician to draw the patient's blood on site, harvest it, et cetera, all the steps that were needed, nor would it cover the cost of the product. So that was
So
a
it's
big concern.
interesting because in CTPs, they don't bundle those two together.
They do. They have the application
Okay.
product and the
But
product
it's just
it's
right off
bundled,
the
but
shelf.
it is off the shelf. And that's the issue here is that, these products are directly, it's taken from the patient's own blood. It's harvested. You have to wait the time, to get it to a point where it's the graft itself, and then you have to apply it to the patient. So there's a lot of extra steps that are involved in using this product and a lot of extra time and effort that the clinicians need in order to use it.
And that's correct, Karen, because we had one of these products in our clinic, and
Yeah.
it kind of definitely we had to look at the workflow because
Yeah.
it increased the time. Not just that, but we had to get supplies that we don't usually carry in the wound care department. So there's an associated cost with that. As a
Right.
matter of fact, it got to the point where we had to decide, do we want to continue with this great product or not?
Yeah.
So
Yeah.
Kind of showing those two sides of coverage is great, but the payment has to match that the
Yeah.
coverage is worth it, right? Like
That's
it's
right.
great that CMS acknowledges this is a great technology. Don't even
That's
worry
right.
about LCDs. We're doing an NCD, like it's
Right.
covered. But the fact that they put the pricing so low is a little bit of a slap in the face to the
That's
technology that they said is appropriate.
That's exactly right. And so, when you look at that, you're like, wow, this is great. They're finally addressing this at a national level so that we can have no variables across the board and, make sure that payment is adequate. They put forward this proposal and we're thinking, oh my gosh,
You're
that's
like,
still not going to
nope.
do the trick. Yeah, it's still not going to do the trick. There's still not going to be access. And so, we're concerned about that, obviously. We don't want them to inappropriately pay because we've seen that on the CTP side when they bundled the product and the service, right? And then
Mhm.
they had a flawed methodology to create the reimbursement. And here we are, how many years later, almost 12 years later, we're still having issues with the reimbursement there, right?
Still
So
on the struggle bus for sure. Yeah.
that's right. That's right. So, the Alliance launched a lot of advocacy efforts. I mean, we met with leadership at CMS in multiple divisions. We talked to the medical directors at all of the MACs. We obviously provided substantive comments. And
Yeah.
the comments that we provided, what we did is we kind of looked at this product and we said, okay, if CMS is going to do a crosswalk to something, because that's kind of what they're trying to figure out, like what payment they can do,
Uh-huh.
it doesn't make sense to do it to CTPs because it's not doing apples to apples there, right? It's not.
Yeah.
And so there's an epidermal and dermal graft code actually that exists. And so we thought that that would be a more appropriate crosswalk code to use. And then when you start doing it that way, and you start seeing the cost of the product and the invoices that were submitted, and then the time and effort by the clinicians, that crosswalk code actually more accurately reflects the cost of the professional time and effort as well as the product. And so we provided very substantive comments to the agency on that. And we'll see what happens. I mean, again, we never really know if the agency is going to adopt recommendations that anybody puts forward. But we know that there was substantive comments in this area, which is unusual. Yeah. So there were at least 40 comments specific to autologous blood-derived products. And that's just unusual in the wound care space to see that many comments on a new proposal. Um,
Mhm.
and so, again, we'll see what happens. We hope it gets resolved in the final rule when it's issued. And if not, we're going to continue our advocacy efforts on that. So it's
Yeah,
a
I
big
know
issue.
Frank and I recently have done a couple episodes with autologous blood derived product companies. And so learning about like their RCTs and showing the great
Ah,
benefits of it, really hopeful in the future that enhanced technology will be able to reach our patients because
absolutely.
it's appropriate in the business model
Absolutely.
of the space as
Absolutely.
well.
And what's so fantastic about it is the evidence backs it up.
Mhm.
It does.
Yeah.
right,
Yeah.
right. I'm sure we can come back to a lot of this, but when I worked in the one clinically, I can tell you the product works great, but then it became the other test business wise, is there reimbursement and all that? And a lot of times we had
Mm.
hard time kind of matching two. But I'm so glad that you advocate for this because to me, we need these products for our patients. But I want the viewers to know. I mean, obviously, Skin Sub is getting a lot of the attention lately, but what else do you advocate that it can encompass the whole continuum of care, not just one setting?
Yeah, so I mean, there's a lot of issues. I mean, obviously there's payment issues that come out every year within the agency, whether it's home health, skilled nursing, hospital outpatient, physician fee schedule. I mean, annually, there are regulations that come out on the payment side of things that address a whole scope of issues, not necessarily specific to wound care, but it could impact wound care, right? So in the hospital outpatient, they addressed prior authorization as an example. They wanted to make it more consistent with what was happening in the managed care space. And so there was a proposal there about prior authorization, which of course we commented on because you still need prior authorization in certain areas in the wound care space, right? And while we still think that the managed care prior authorization requirements are still too long to get a determination, to get a decision, we believe that it should be at least consistent across the board. And so obviously we're in support of that. There's telehealth. Obviously, there's a lot of expansion that's going on there that we also support. But there's also something in the physician fee schedule that was also issued, and that had to do with caregiver training. And this is an issue that we talked about in your last show as well, where CMS proposed new codes to allow for payment for caregiver training services. And that's a good thing because, quite frankly, clinicians are already doing that. So you might as well get reimbursed for your time, right? But the codes that they put forward are for caregiver training services to take place without the patient present. Okay. And CMS specifically stated that that would include instructions and techniques for decubitus ulcer prevention. Now, decubitus ulcer is their term, not mine. It's outdated. But they said decubitus ulcer prevention, as well as wound dressing changes and infection control. Okay. And that can all be done by telehealth without the patient present. And I think we all support, again, this is sort of what we talked about, right? We support the concept of having clinicians being reimbursed for their time in training caregivers. But in most circumstances, patients should be present for wound related caregiver training because you want to have improved patient care, including care provided by non-clinician caregivers. So, I mean, we all strive for that, but it needs to be done correctly. And inappropriate training can result in serious consequences to the patient. And it's hard sometimes to do that training without seeing the wound, right?
Yeah.
So we're a little bit concerned about that. Needless to say, again, we support it in concept, but there were a lot of details that were short. They didn't provide a lot of details on how it would be implemented, of course,
Yeah.
right?
Well, as mother would say, the devil's in the details, right? And
There you go.
that's the important part, but that's also true for our patients. Like they need the details of how to do this. And when
Right.
we have business models telling us get the patient in and out,
Yeah.
how do you make a case for providing appropriate education other than that soft cost of not getting sued because you didn't educate them?
Right. That's right.
It's super
That's
challenging.
right. And in the wound
Sure.
space, again, I mean, seeing the wound is really important, right? I mean, how do you tell the caregiver what kind of dressing or dressing change to do or how often if you can't see, how much exudate might be coming from the wound or whatever, what the wound looks like, right? And as time goes on, if the wound is changing, your training might be somewhat different, right?
Mm.
So it's a little bit concerning. We provided some substantive comments on that because again, there are some areas that you can do caregiver training in the wound care space that would be appropriate without the patient, but so much of it is wound dependent. Like that's a little bit difficult to do. So anyway, our goal obviously is to have caregiver training services being reimbursed, but do so in a way that doesn't negatively impact patient care or wound healing outcomes. And so again, we provided substantive comments on that, and we'll know again when when the agency issues the final rule if they address some of those comments and concerns, and maybe put a little bit more detail in there to address some of those concerns.
Now, I do want to actually, I want to say this. Um, Karen, in a
Uh-oh.
minute, I want you to wrap up this package and you get it wrapped. You know where I'm going with this. For those of you listening, from firsthand experience, and when I go across the country, we do have problems with lymphedema reimbursement. There's a lot
Oh,
of things that we can talk about. So here's where I want her to wrap up, because I want you to tell us what's happening in that space, because it is crucial for the survival of us lymphedema therapists.
Yeah. Yeah.
I
No,
like
thank you for
I
saying.
like your pun.
Yeah.
Yeah.
That's a good
Yeah.
pun, Frank.
It's
Yeah,
a
Wrap up,
really
the wrap up.
wrap up. Yeah. That's a
exactly.
good one. So, it is a big issue. I mean, it's, the Lymphedema Treatment Act was passed in late 2022, and it created this great benefit, right? And we were super excited that this benefit was finally there to allow for the compression garments to be reimbursed and all this. And well, when something gets passed by Congress, of course, then it goes to the agency to implement it. And that's where we sort of had a little bit of a failure, right? So CMS decided to issue these regulations impacting lymphedema and the compression treatments. But oh gosh, they didn't do it exactly right, did they, Frank? And
Mhm.
what they did is basically allow for the payment to be provided not to the clinician, but to the supplier. So all the money goes to the supplier, and then the supplier is responsible, theoretically, to pay the provider for or the clinician for their service. And that
Mhm.
has been not well received. And it's not really going well because many clinicians are not being reimbursed for their services. And that certainly was not the intent.
Mhm.
So, where do we go from here? I'm sure you're wondering. So, the Alliance decided to take an opportunity to put comments in our home health comments for the prospective payment system because that's where the benefit was put forward. Even though there wasn't anything about lymphedema in the home health prospective payment proposed rules, we took that opportunity to put something in there to say, hey, why didn't you address all these problems we told you were happening in this space? We know that it's not germane. We know that it's not germane to the current proposed rule. But in putting that in there, it elevates the issue. It shows that we're still concerned, and it allows us to get back into the agency to continue the discussion. And it also allows us to go back to Congress and say, here's what's happening. It's not being done right. Our clinicians are being negatively impacted, and they are. So we don't know
Well,
where it's
and
going to.
our patients are
Yeah.
being negatively
Oh,
impacted
for
because of it
sure.
as well, which is, whenever they make it harder to do
Yeah.
what we're supposed to be doing, it's so
Yes.
frustrating.
It is.
And then unfortunately it trickles down to the patient where there's a lack of resources, there's a lack of access, it's
Absolutely.
super challenging.
No,
Absolutely.
no,
And
it is challenging, and I do have to say this because I know I talk about it a lot. But most people, when they think of lymphedema, they think of upper extremity breast cancer. That's not the patient that I deal with. The
right.
patients that come into my clinic have bilateral lymphedema, lower extremity swelling. They have a big pannus. They have other problems, and I can spend minimum 2 hours with them, and I don't have time for that because of the reimbursement. But also, when you start looking at measuring patients, now I have to send them somewhere else because I don't have the time, and sadly
Right.
to say, and that's what we're facing.
That's
Yeah.
so sad to hear that.
It's not only sad, it's inexcusable, quite frankly, because again, as you said, Lizzie, the patient is the one that's really suffering, right?
Yeah.
And it's also impacting the clinician's business model because they're not getting reimbursed for services that they should be. And so it's sort of a domino effect, right? Where they just don't do
Yeah.
something right at the initial level. And then there's this trickle effect down, and it's negatively impacting care by clinicians to their patients, which really is, again, not what the intent was of Congress
Right.
when they created this benefit in the first place. So we're hoping we're going to continue to advocate to make those changes, to add new codes to allow for, additional codes to allow for additional reimbursement. And if need be, we'll go back to Congress and let them know that what's happening at the CMS level is continuing to negatively impact patients and providers. And that's not what the intention was when they created the benefit in the first place.
Yeah.
Mm.
Well, thank you
And
so much for all
and
that you're doing.
thank
Thank
you.
you.
And I'm volunteering Lizzie and I to help you with that because we need
Yep.
help because these patients have wounds as well.
Yeah.
Yeah.
So I just want to remind our listeners if they want updates to what the Alliance is doing, or if they want to stay on top of what is happening in terms of any proposed rule or comment. I mean, there's so much for people, and to be able to digest this in a timely manner. I think you've shared with us before how volume uh rich some of these proposals are, and how you really make it easier for our audience and for your audience to receive those. So where can we go in order to stay on top of the latest and greatest that the Alliance is doing?
Sure. So, I mean, obviously, we have a LinkedIn page. So we certainly always post stuff there. So, certainly get connected to us there. And we also have our Alliance website, that they can go to take a look at it. It's alliancestakeholders.com.
Yeah.
I'll also let your listeners know that when we talk about these proposed rules, they do get issued in final at some point, right?
Yeah.
And that's really what we care about, because what it gets issued in final, it gets implemented in January. And we're expecting those to come out at some point in November. So it's right around the corner. We'll
Great.
know what's going to happen soon. And so happy to come back and kind of go through that with your listeners and let them know what ultimately ended up happening. And hopefully we get some of the changes that we've been advocating for.
Great. Well, we'll be sure to set aside a larger chunk of time for those final proposed rulings, because I'm sure we'll have a lot more to talk about when it's not theoretical.
Yeah, true.
Great.
Very true.
Yeah.
Mm.
So I do want to say, Lizzie, for the viewers, don't miss out on this. Subscribe to us. We're on LinkedIn, YouTube, Facebook, and Instagram. And so
Great.
join us and we'll keep you updated on the latest from the Alliance.
Yeah. Thank you so much, Karen, for spending time with us and updating our listeners. We truly appreciate it. And thanks to the Alliance in general for all the work that you're doing.
Thank you so much. It's a pleasure.